welcome everyone for our second PTCOG Ocular Proton Therapy webinar. Today's topic is Ocular Proton Therapy at MedAustron using a non-dedicated beamline. The presentation is given by Patrick Scharpf-Roisl. Patrick is medical physicist at the MedAustron in Wiener Neustadt, and he started at MedAustron in 2020 as project lead to implement the non-dedicated ocular beamline and slowly transferred from system development and CE certifications towards clinical implementation. Aside from ocular proton therapy, treatment planning with protons and carbons, TPS commissioning, end-to-end testing, PSQA, and MDR topics are part of his area of responsibility. Patrick, please share your screen and start with your presentation. The floor is yours.
Thank you very much, Jens. Thanks a lot for the invite. I hope you can see my screen already. Then I take this as a yes.
Yep, it's working.
Perfect. Then let's get into the topic. I'm very happy to present today how we implemented here at MedAustron the possibility to treat ocular tumors, especially uveal melanoma, on a non-dedicated beamline. So today I'm going to go a bit through, first off, what were our project requirements, where do we come from, what was the starting point, then talk a bit about the development, what did we implement, what needed to be adapted, what did we change, show a bit the results of all these research, and then at the end present you a bit the clinical workflow that how we treat currently patients. Right away, I want to tell that at the moment we treated 40 patients. Within the last year, we started treating the first patient in December of 2024, and we estimated 10 patients in the first year. We already treated 40, so it's up and running and going quite well. I will give a short introduction about uveal melanoma, but just very superficial, because I guess most people here have a lot of knowledge on uveal melanoma. So the uvea is consisting of the iris, the ciliary body, and the retina. 95% of uveal melanomas actually come from the ciliary body or the retina. And I also have to say that at the moment we're not treating iris melanoma. They can occur either dome or mushroom shaped, mostly if they extend beyond a specific size. They sometimes break through a membrane and then build this mushroom shape inside the vitreous body. So of course, what are the main challenges of uveal melanoma? We talk about small target volumes, sometimes just 2 to 3 millimeters in a diameter and a height of roughly a millimeter for some of these tumors. We have a lot of sensible organs at risk in a close vicinity. Of course, the optic nerve, the lens, the eyelid, ciliary body, retina, macula, or the whole eye itself also, of course, is an organ at risk. If too much dose is delivered to the eye, it will not keep its functionality as well. It's of course a very mobile organ because we can move our eye by free will, but also it moves without our free will, which is more of an issue in this case. And proton therapy, or in general radiotherapy for ocular tumors, is very well established and a very successful indication in radiation therapy. We have a lot of data on very high tumor control rates starting out 50 years ago at the Harvard cyclotron already. So what were the requirements when we started with the project? First off, we had to replace an existing system with a stereotactic treatment at the Universal Hospital of Vienna, which was going towards an end of life, because especially now considering the new regulations according to the MDR, and it was an in-house developed system. We here at MedAustron have an in-house developed pencil beam scanning synchrotron, the so-called MAPTA, and we wanted to utilize a non-dedicated vertical beamline. Why the vertical beamline? Well, that's because we have a patient couch in our room, so our patients are immobilized in head-first supine, and we did not have an opportunity to use a chair and treat in seated position, as is the state of art most of the time. But at the end, we always kept as a goal that we want to have the same or even higher, if possible, treatment quality as dedicated eye beamline centers. So regarding development, our first step was, of course, how to solve the issue of the movement of the eye, and then we got in a very traditional approach of having a system with an LED for gaze steering and a camera for eye surveillance. So this was the first challenge that we needed to meet. While additionally, we also thought about how do we reach beam properties similar to dedicated centers. So we want to optimize a dose distribution to have very sharp penumbras. To solve these two issues, we actually had to develop a C-certified medical product where we needed to hand in at the end around 330 documents in total to have a medical device accessory to our accelerator. And the second part of the beam optimization required an increased intensity. Because of the setup system, which I will explain a bit later, we lose a lot of intensity and therefore we had to increase it. And therefore we optimized our synchrotron by reducing the spill length to have a faster beam delivery. Then, of course, we need to look into how to optimize and adapt our clinical workflow to make it feasible to treat uveal melanomas. Of course, we had a look at optimization of immobilization technique and imaging modalities to make up for these very tricky targets. We implemented a way to have treatment planning both image and structure guided to use, so to say, the best of both worlds. We created a fully new in-room workflow for patient positioning and position verification. We developed multiple QA processes to verify the proper treatment of the patient, and all of this is also verified and documented. We also integrated the use of tantalum clip markers, which are sutured onto the sclera by ophthalmologists in an ophthalmic surgery. That means we had a very close cooperation with the Universal Hospital of Vienna and the Department of Ophthalmology there. These clips are usually sutured to the sclera in one surgery session. They have a diameter of 2.5 millimeters and a height of around 0.3 millimeters. And they are necessary for precise target positioning in the room, because one of the main issues of the eye is that it's basically water and you cannot properly depict the structures well enough in a typical optical X-ray system to position the eye within the precision that we want without any additional references, which are these markers. So here we can have a look at the results. First off, the first part of the medical product would be our tracking device, which main features are the positioning of an LED above the patient's head and of a camera. The LED can be moved, it can be rotated around the inferior superior axis around the patient to steer the gaze in any intended direction, and additionally it can be moved along the inferior superior axis. So we can reach any rotational position of the eye that we want to. The camera setup that we see here is actually an old version, which we upgraded by now. And we now have an independent camera holder mounted to the table, which is more freely moved in the room. And that makes it easier for us to prohibit the camera being in the path of the X-ray images, being in the path of the LED, or colliding with the nozzle. The second part that of course belongs to the camera is eye monitoring software. It's a system that gives us a live image in a local control room with the opportunities to crop and zoom into the image that we take and see on the live image also structure contouring. That means we can verify with some contours whether the pupil, for example, is still in its position, but we also like to mark some anatomical structures like the eyelids or the eyelid retractors to differentiate between eye movement or head movement. The third part of the medical device is our so-called passive beam modifier. It's a nozzle extension that is mounted to the vertical nozzle, and it works in a way that we actually use single central spots coming from a synchrotron, which are scattered by a range shifter, which is positioned upstream inside the nozzle. And then we have the far scattered particles absorbed in this plastic absorber, and only the very straight particles make it all the way here to the isocenter, where we can position a patient-specific brass collimator, which is drilled in-house with a CNC drill. What we still do for energy scanning, so from the pencil beam scanning system, is that we do energy scanning to create an SOPP. That means we don't use any passive scattering system for range modification like a range modulator will. Let's go a bit to commissioning. How did we actually get to how did we determine how good our beam is and how much we can do a proper simulation? So what we actually use for those simulation is the pencil beam scanning dose calculation algorithm based on Monte Carlo version 5.6 in RayStation 2024A, which means our beam model that we created in the system is a copy of the IR2 VBL model, where we just integrated the collimator and performed an energy-specific calibration. We have the possibility to calculate the dose on a 0.5 millimeter dose grid, and we verified also the interpolation that is done by RayStation for the precision of the dose calculation. The results showed us that we have a mean local dose difference within the SOPs under 1.5%, and we have a mean global dose difference in the ramp-up area and the distal fall-off below 2%. I can show you some example SOPs that we measured. There we see some absolute dose measurements with an advanced Marcus chamber. We also performed the same measurements for redundancy with a microdiamond detector, and we see the match in the SOPs. We performed extensive and precise evaluation, especially in the distal range. We verified the R80, R50, and R20, and we can see here that our mean differences are below 0.1 millimeter, with a standard deviation of roughly 0.05 millimeter. For lateral profiles, we performed some measurements with GAF-chromic ABT-free films in water. We performed a two-dimensional gamma analysis. There we see pass rates of more than 97% for 0.5 millimeters 5%, and 0.3 millimeters 3%, and pass rate above 90% for various collimator sizes. Let's have a look a bit on the beam parameters. So I was talking about wanting our parameters to match with that of dedicated beam lines. And then we can see that our distal dose fall off from 80 to 20%. We have within all the modulations from 0 to 3 centimeters, we have a distal fall off of 1.0 millimeters. So we can see that it's very comparable to that of dedicated beam lines, where the mean value is 1.2 millimeters. Of some dedicated beam lines I excluded for the mean calculation the Florida beam line, which is beyond 3 millimeters. But we can see that we are in a comparable range. Only Jens in Berlin is beating us to the point. And if we look at the lateral dose fall off, also from 0 to 30 millimeters in water, also our mean value is for a 25 millimeter circular collimator is around 0.8 to 1.8 millimeters, which is also comparable to that of dedicated beam lines. There we see that Nice is a bit sharper than we are, but I would say this is all within acceptable terms. So let's have a look. How do we now utilize this system that we developed to create a nice beam and to have the possibility to steer the patient case? So when the patient first comes to see us, he's having a baseline interview with the radiation oncologist, and we perform an initial 3 Tesla MR with microcoils and closed eyes of the patient. We don't do any immobilization prior. This is just to get a knowledge on the position of the tumor within the eye. In the second step, the patient goes to clip surgery. There is tantalum clip markers are sutured onto the sclera. We usually use 3 to 4 markers at the moment. We measure all the distances between clips and clip to tumor and clip to limbus, and we note them down in the surgery report. We also put down roughly the position of the clips and the tumor in a fundus projection on the clip on the surgery report, and we use it as a reference for a tumor position at the end, because this is the main point for the in-room positioning. What we actually position is the clip, and we hope that in the planning we position the tumors close to the clips, or we know the distance between tumor and clip, let's say like this, and then therefore position our target precisely in the beam. We can see here how a typical surgery report looks like, where we note down all the important data within of the surgery. Next, we perform the patient immobilization, usually 2 weeks after surgery, so the eye has time to heal. Sometimes we also perform it a bit earlier if necessary, if we need to treat the patient more quickly. Demobilization is performed with an encompass screw-fixed tabletop, and we use a mold care in the back of the head, plus a mask and a bite block to properly position the patient's head. We also can adapt the mask after the hardening around the head to make sure that we don't tighten the skin too much and it's easier to pull the eyelids out of the field. We have the possibility to rotate or extend the head if we find it feasible. We now try to make a proper guess on a good gaze angle already from the prior MR images for the patient, and therefore we can evaluate where we possibly need to rotate the head to, because in this lying position, one of our let's say disadvantages compared to the seated position is that in the room we don't have the possibility to additionally rotate the patient head. So we try to take this information prior and say, for example, we try to rotate the head slightly to the side to make sure that the noses will not be in the beam path, or rotate it, extend it upwards or downwards to make it easier to pull out the upper or lower eyelids. Once the patient is immobilized, we then perform a CT. In the planning CT, we already have the patient mask. We use an LED to steer the patient into the intended direction. There we have the information from the MR and fundus in which direction would be the most feasible one. And we also check already what's the maximum angle that the patient can actually take his gaze. In this way, we then perform the CT already with eyelid retractors inserted and with the eye position surveillance. So we already make sure that the patient is looking into the intended direction, and we perform a dedicated CT where we have a protocol of 0.8 millimeter slice thickness. Afterwards, we perform an additional MR, and this is our planning MR. There we use also the microcoils for high resolution of roughly 0.4 millimeter in plane resolution. We got some dedicated sequences developed at the LUMC and provided thankfully by Jan Willem, who's also present today, and we perform MR both with and without contrast enhancement, and importantly, we also now perform them with clips. I will come to why we do it with clips later in our treatment planning workflow, because what we intend to do is to create an eye clip and tumor model in RayOcular module, which is positioned within RayStation that allows the creation of an eye module. We perform image fusion of the MR with clips to the CT with clips and the fundus images based on macula, optic disc, and tumor position. After creation of this model, we can also, during the creation of the tumor model, integrate the dimension of the tumor based on ultrasound measurements and the clip surgery data. We can also verify the clip positions based on the data that was taken during the surgery. The target definition is a very close collaboration between medical physicists, radiation oncologists, and the ophthalmologists in case there's uncertainties, especially regarding the differentiation of ablation to actually target volume. For plan optimization, we create a PTV, which is a 2.5 millimeter anterior and posterior extension of the CTV, and we add a lateral target margin of 2.5 millimeters by extending the collimator. We always make sure that our PTV is covered with at least 90% of the dose, of the prescribed dose of 60 gray, meaning 54 gray. And we actually perform inverse dose planning as we use the pencil beam scanning Monte Carlo algorithm in RayStation. We still have the possibility, in case we consider the eye rotation that was taken in the CT not the best one, the best case scenario, we still have the possibility to virtually rotate the eye within the treatment planning system, and we get a new, we wrote a script that puts out a new LED position that is then consistent with the new eye model rotation. We can see here some images that I prepared. So here we see the clip-based MR to CT registration. Up on the slice view of the CT on the left side and the MR on the right side, and below we can see the verification. It can also be nicely done in the fundus projection of RayOcular. If we look at treatment planning, then of course we can then review our target is first delineated based on the fundus projection in the MR and verified with the fundus registration, and we can then do a review slice-wise on CT, MR, as well as in a 3D model. And this also always helps the ophthalmologists a lot to verify if this is what they actually saw in the patient eye. Because at the end, what counts is the ophthalmologist knows how the tumor looks like, but he needs to transfer this knowledge and into what we need as a model of the tumor. Here we can see also then the verification of the clip matrices. That means the clip to clip distances, clip to limbus distances. We can check, verify the clip to sclera distances, whether our model is reasonably placed, all towards the surgery report. We can see here how a typical dose distribution for a rather anterior tumor looks like. We can see that we nicely rotated the anterior optical structures out of the treatment field. Distance, we have the 2.5 millimeter extension beyond the target to cover the target. We can see the very sharp lateral and distal penumbra here with a fall off of roughly 1 millimeter. Of course, helping here is the very shallow location of the target. And we can see, of course, we have full PTV coverage while zero dose is delivered to anterior structures because they're rotated out of the field, or distal structures like the optic disc or the macula. What is an advantage of using the RayStation system is that, of course, we can also utilize any other functionalities within RayStation that are used in image-based treatment planning, like creating an 3D structure. So this patient structure, for example, we also create already for the immobilization. So we have knowledge on where to position eyelid retractors. And then we got also this information from the planning phase from the CT, which we can transfer to the room to tell them, okay, during the CT acquisition, the eyelid retractors were in this position. We see that now the projected field of the treatment would fall onto the upper eyelid. So it's necessary to pull further into this direction. So we have this a priori knowledge as well, and we can provide a field light printout for the field light check after the immobilization, which I will come to in our patient treatment workflow. I also brought one of our examples, a patient we treated this last summer, a patient 57 years old with a rather large uveal melanoma of 9 times 7.5 millimeters and an extension of 3.4 millimeters. Interesting part, the macular tumor to tumor edge was exactly 2 millimeters or 2.3 millimeters, which is exactly in our range of the distal PTV margin that we usually choose. But this patient was a radiologist, so he's very depending in his work on his site, and also a patient we could talk in very much detail on what we're gonna do. So as we saw in the dry run, that he very well held his gaze, and it was very easy to position him. We decided to give him the choice and decided to go with a 1 millimeter distal PTV margin, which meant we could actually keep the macular dose to a D2 of 30 gray and a D50 to 16 gray. And of course, zero dose to the optic disc as it's on the contralateral side of the tumor. So now let's come to the actual workflow when we start the treatment of the patient. We always have a QA procedure whenever we treat eye patients. They're usually treated within a normal everyday treatment. So that means we usually start after lunch break to mount the passive beam modifier. After the mounting, we align the position with a registered table position, which can change on a daily basis. That means we make sure that the offset between the daily table 0 position and the passive beam modifier ISO center are within 0.3 millimeters. We therefore developed a dedicated phantom which holds clips for registration purposes, an advanced Marcus chamber for absolute dose measurements, and also a film for alignment measurements. Additionally, we also measure the dose intensity during this QA process. We have a crosshair collimator mounted in a passive beam modifier to verify the position. And afterwards, of course, we also perform a patient-specific collimator QA. The whole QA process takes roughly 10 to 15 minutes, depending on the experience of the medical physicist on duty. So for patient positioning, we first have the patient immobilized in the treatment mask. We position the LED in the intended position, tell him to please look at the LED, and then we take a reference image in our software and contour the eye in the monitoring software. We then perform orthogonal X-rays with a table-mounted imaging ring. This imaging ring you can see here, which drives up to the patient, takes one orthogonal X-ray image in this direction and another one in the orthogonal direction. These images can then be registered in Ray Command using the clip structures that are exported from the treatment planning system. At MedAustron, we use the full Ray World package, meaning RayStation, Ray Command, and Ray Care, which makes the transfer of this image data also very easy. What we do is we register the clips to the clip structures, and we get an offset, which is then here depicted in a pitch and a roll, which means a rotation left-right and a rotation up-down. So we actually use pitch and roll instead of azimuthal and stuck on a name on the traditional ways of calling the gaze angles. And then we correct for it by using a lookup table and a decision tree. Our decision tree starts at 2 degrees for the first 2 imaging iterations and then is increased stepwise, and we would accept for 1 fraction maximum of 10 degrees offset. This is how the final position looks like. This is a proper registration. We see here that our pitch and roll are well within 2 degrees. And then finally, if we're okay with the rotational offset, we perform a translational correction by moving the table, and we can also correct for a yaw of the eye with the table rotation in case there's a yaw present. Let's talk about a bit patient positioning reproducibility of this system. I think this is one of the main advantages of the lying position and this a priori knowledge from the CT. So for the first year, we applied more than 120 fractions, and I did an evaluation, and I saw that for 40% of cases, we just had a single iteration of images for the initial setup of the patient, meaning we just immobilized the patient, position the LED in the same position as last time, take the images, and we are within the 2 degrees rotational offset. We had to perform more than 4 iterations in only 1.5% of fractions. So just a very small amount of patients where we actually had to do multiple iterations. And if we look at the rotational deviations that we accepted at the end, we had less than 2 degrees in 35% of fractions, less than 3 degrees in 65% of fractions, and less than 5 degrees in 96% of fractions. There were just a few cases where we accepted a higher offset due to struggles with positioning the rotational, the eye rotation with a patient, and this usually always also only occurred in the last fraction or second to last fraction if the initial fractions were within fine limits. What I also want to mention is that the resulting lateral offset from the rotational mismatch is additionally minimized by choosing a translational correction which centers in the mean deviation of the clips. So it's not a 5-degree offset, does not mean a 5-degree lateral rotational offset. At the end, when we corrected for the translation and twist with the couch, we then have a light field for the treatment field confirmation, which we compare to the printed out light field, and there we also check whether the eyelid retractors are in field or we should further pull the eyelids to get them out of the treatment field. How does our clinical workflow look like? So for treatment, we have one dry run for the patient always, where we check first off the feasibility of the patient being able to reproduce the gaze that we had in the CT, or being able to look into the position in case we rotate the eye virtually, and then his ability to keep his gaze, and we check whether the eyelids are pulled from the field. We then treat in 4 fractions of 15 gray on 4 consecutive days. Our in-room time is 20 to 50 minutes, depending on the number of iterations that we need to do for the imaging, and it's an average of 30 minutes. The beam-on time currently is 2 to 3 minutes. As mentioned, we already had a project to decrease this time, and there's projects going on currently to further decrease the beam-on time. We perform manual interruptions or breaks for the patient in case of position displacements. Now coming to what are the next steps that we want to get going. Right now, we're working on the introduction of wedges in the clinical workflow. I currently have a student working on that, and we did some measurements in December, now evaluating the final data and hope to be able to clinically implement them by February. We want to reduce further the beam on time. There's also multiple projects which should fine-tune the accelerator going on at the moment. And we're permanently optimizing our equipment and workflows. We have a steep learning curve now in the first year. There's a lot of things that you could not consider until you have actual patients on the table. Of course, nothing of that goes into treatment quality, but it just makes our lives easier and our workflows more efficient. For example, we upgrade a medical device with this new camera holder, which is more easier to handle than the old one. We improve the mask system with the cutouts, that it's easier for us to pull the eyes from the eyelids, and also we're looking into some new eyelid retractors at the moment to maybe improve this system as well. Of course, what we also want to do is to optimize our treatment margin to improve organ at risk sparing. At the moment, we're using the 2.5 millimeters, which is a historical value. There's a lot of nice publications also from the Essen group on the feasibility of these 2.5 millimeters. But of course, we're striving towards a more fitting approach for our system. So we would like to further look into our options that we have, especially using this image guided approach and so on, to maybe at least reduce the distal margin for better organ risk sparing. And we currently have multiple clinical studies ongoing. Of course, we need to collect now all the data on treated patients so we can see if at the end we actually reach the same treatment quality as dedicated beamlines. That would be it from my side. Thank you very much for the attention. I'll be very happy to take any questions.
So thank you very much, Patrick, for your very nice presentation. I would say the room is open for questions. Either raise your hand or write them into the chat. So maybe let me start with the first question. When you apply the lid retractor and you need to change the position, sometimes in our case it happens, then also the position of the eye is changed. Do you recheck this?
Yes. Whenever we change anything with the eyelid retractors, we need to re-image because we see this effect as well. The eyelid retractors have a large impact on the rotation and position of the eye.
Okay, thank you. Then the first question I would say would like to ask Julian Maguresh. Just open your mic and your camera and raise your question.
Yes, hi. Thank you for the great talk. I was wondering regarding the eye monitoring software. So the reference for the position of the eye, is it from the reference at the CT or it's before every single fraction?
It's before every single fraction. It's actually, we retake the reference image every time we change anything on the LED position. So of course, as soon as we change the LED position, we take a new reference image because the reproducibility is quite nice to the CT, but also we have different light conditions and so on. So it's very hard to use these old reference images as a new position because with the translation, we also make up for any mispositions within the mask. And this you would see immediately. So the precision should be much higher than what we can see in the reference image from the camera. Also, the camera position is different every time because we have it table mounted. So it's not fixed to the patient mask or anything.
Thank you.
We had this thought initially, actually. That's why this first design was to the camera on the LED holder, so we can have it in the same position always. But this quickly showed us that it's really tricky to get a position which doesn't collide either with the pipe coming from above or with the orthogonal X-ray system and have the eye in view. Very tricky.
Thank you.
So next question from Martin Jansen. Martin? You're still muted, Martin, somehow.
How about now?
Yeah.
Now it's good.
Okay. So thank you, Patrick, for a fantastic presentation, and congratulations on an incredible job that you guys have done at MedAustron with this. It is very impressive. I wonder, could you say a few words on how you delineated the tumor? You see, I think you noted it where you used MR and fundus. Do you use both? Do you sort of combine the outlining in the 3D images, MR, and with possibly what you can create the tumor in the fundus view of RayOcular?
Yes, so I'd gladly go into that. Just don't want to take too much anterior because I actually prepared a nice abstract which I sent in for the PT Cognitive yesterday regarding this topic. But I can quickly guide you through it if we go back to the slides. So what we typically do is that we perform the registration between MR and CT based on the clip positions, which we then have a peer review to check if the registration is acceptable. And then we have first the radiation oncologist delineate the MR-based tumor as he would do for normal treatment. And then I take this structure, view it in the fundus projection, and based on the structure and what I can see of the MR base in the fundus projection, I delineate the new structure and then additionally verify it with the fundus image and ultrasound measurements. So it's a combination of all the figures, and then we can do a final review in the CT slice-wise as well, and could then still adapt if necessary. So it's a bit of a back and forth between all these imaging modalities.
So you always delineate the tumor in the 2D views and not in the fundus view?
The final target is delineated in the fundus view. We start in the 2D view to have like a first guess based purely on the MR, and then the final target is always done in the fundus view, which is also something that we do because if we do the virtual rotation of the eye, the target only rotates with the eye if it's delineated in the fundus view and is a actual target in the eye model. That's why our final target is always done in the fundus view as an eye model target.
Then I guess a lot of questions are popping up. I would like to continue. Jan Willem would be next.
I have a question which continues a bit on Martin's question. So I see you use CT imaging as well. So what does it add you compared to the fundus and the MRI image?
We got a script from Martin, which very, very precisely locates the clips based on the clip artifacts in the CT. And what we get from the clip is the surface of the patient, because we already used the eyelid retractors. First off, we know about the patient's surface, which we can use for those calculations. So we have our entrance surface, and we see the position of the eyelids and where we possibly need to pull further, or if it's even infeasible, if we say, okay, the eyelids we pulled already as far as we can in the immobilization, and we still need 5 millimeters, then we would need to say, okay, we need an additional immobilization, otherwise we'll not be able to pull the eyelids during the dry run.
Thank you.
So
very impressive work.
Thank you.
So next question from Jan from PSI.
Patrick, you said that when you are finalizing positioning, there is this, you're basically allowing for some residual rotation, and you were showing what is the likelihood of that rotation. Based on what information do you decide whether that is acceptable rotation for that particular patient?
So we actually have a lookup table, which is based on an evaluation which purely works on statistics. So if we said, okay, for a standard eye, 2.5 centimeter diameter, 3 degrees result in this much offset. So that's where we're based on, and that's why also the 10 millimeter is the maximum allowed, which should still be within the PTV target margin. But also we saw very quickly that for the majority of cases, we really managed to be within the 2 degrees. And I'm talking about 2 degrees in 2 directions, which is then, if you look at the square sum, a bit more than 2 degrees. But we're still within 3 degrees in 65%, 5 degrees for 96%. Usually, we decide also based on the patient performance. We see a lot of patients that just never manage. So if we had patients that were always within 4 degrees, they never managed to be below 2 degrees. Then we also make notes. So we have a dedicated protocol, which is filled out by the radiotherapists and the medical physicists in room on patient specifics. Like, I mean, there's very simplistic things like patient just listens to mail commands is a very important note, for example, or we note down, okay, patient was never positioned within 2 degrees, so accept 3 degrees in the first iteration. So it's a bit a learning curve for us as well, because we thought first we're going to use this fixed lookup table decision tree, but the decision tree then showed its limitations based on patient performance.
And one more small question. When you were showing the slide where there was the metric of the clip to sclera distances, there was one clip with a 2 millimeter distance from a sclera. I guess there was some help structure or something. And
yes, this is actually something. Let me check.
So what would be the
yes,
tolerated deviations?
Exactly. So we accept from 0 to 0.05. It's centimeter here. So up between 0 and 0.5 millimeters would be acceptable, depending on the shape of the eye. We usually land between 0.1 millimeter and 0.2 millimeters. Just if the eye has a weird shape, which we had like 2 patients, we accepted a higher offset. And the clip 4, in this case, the clip rotation script that we wrote for rotating the eye rotation script that we wrote, we hard coded it to 4 clips, and then we just switch 3 clips. Sometimes then we need to make an imaginary clip somewhere. So it's a bit of.
Thanks for the great presentation.
Thank you.
We will continue with some questions from the chat. First one was from Kataram Darakia. Hi, nice presentation. Could you please explain the planning approach based on PTV instead of CTV? Have you considered the range uncertainties in the optimization?
Yes, so actually we delineate the tumor base and we just then extend it 2.5 millimeters posterior and anterior as a planning target margin and make sure this is covered with the 54% dose. As we use this PTV, we don't use any range uncertainties in the optimization, but we consider the 2.5 millimeters as our range uncertainty. We currently override the structures due to the artifacts created by the clips, but we performed some evaluations also on calculated CT Hounsfield units to make sure that this is that the range uncertainty due to the override is within acceptable terms.
Thank you. Next question is from Juliane Darts. To create the fundus projection, do you use the exact geometry of the camera that was used to acquire the fundus image?
I have to give a strong no there. We just use the polar projection. We don't use the camera mode currently. For us, we don't visually use. We don't visually use the fundus projection, but what we use are measurements that we see and which should be equivalent. So it can be, you can use it a bit visual. So we scale it to the distance between optic disc and macula to be accurate. And within this area, so within a distance of 3 millimeters, it's rather accurate. The further you go from this central path, the less you can trust also OptoMap images in general, we have to say. So there we then make the best trade-off. But for us, the most important part, the most important information you get from the fundus is the distance between tumor and macula or optic disc. Because any anterior, we rather take the worst case scenario, depending on if it's further in the ultrasound measurements, further in the MR, we tend to take the worst case scenario because anterior, we're not hitting, I mean, the anterior structures are either rotated out of the field or not. But what's important for us, or the most important part, I think, to spare is the distal structures, and there the fundus projection is helpful. But no, it will never fit properly, especially for anterior tumors. we just used the polar mode. We didn't manage to find the proper camera mode. And there's also publications from Jan Willem which show that the actual projection of an optomap image is much more complicated than a simplistic ray path calculation.
So we go on. Next question is from Peter Grübling. Hi, Patrick. Very impressive. What have been achieved? Congratulations. My question, what reduce of beam time do you think is feasible with the MedAustron machine?
Currently, we have two projects ongoing. The one is B-field magnetization optimization to faster accelerate the particles, and the second project that we have ongoing is to further reduce the spill length to 1 second. As I know, with our current DDS system, the 1 second spill length is the maximum where we can properly detect the delivered dose. So there we reach the limits, and the B-field optimization gives an additional good part, and we talk here about 40% beam on-time reduction. So roughly 1 minute to 1.5 minutes of treatment time. That's what is on the horizon, I would say, within the next 1-2 years. Further, I think then we're also pretty much at the limit, honestly.
So next would be Guido Baroni. So please ask your question. You are muted. Huh? Sorry? Guido Baroni? Or is it Mark? We cannot. You're muted. You can unmute and speak.
The question is in the chat.
Ah. All right. Did not find it. No, another.
I see.
So then there's it. Hi, nice presentation. Do you require additional X-rays at each patient break with irradiation when back to gaze direction, or do you trust manual drawn contours?
So we usually trust the contours unless we see an offset in either in the head rotation, so meaning the help structures from the eyelids or the eyelid retractors, and an offset of the lens. Otherwise, we trust these manual drawn contours, because usually you see it quite well if it moves from there.
Okay. Next question is from Ricardo Villa. Ricardo?
Hello, thank you. Thank you for the presentation. I noticed that you use for planning the MR with the clips on, and yet you have available an MRI without clips. I understand why you do that, but I was wondering if you ever check if there was. So do you find that an MRI without the artifacts with the clips does not give you any more clinical relevant information than the one with the artifact with clips, or you just didn't check?
We did a verification of both, so we compared, of course. We don't get additional information from the MR without artifacts, and of course the registration cannot be as precise without the clips, because even though we could register based on the lens and the optic nerve partly to the CT, the optic nerve has a high tolerance in the CT. It's very wide, the optic nerve sheet, especially as the eye is in a different rotational position. It's very hard to use this as a reference structure in the registration. So the clips, we'd rather have the precision of the clip registration than the additional information from an MR without clip artifacts. But honestly, the clip artifacts don't affect the tumor visible in the MR.
Okay, thank you.
Welcome.
Then we have a further question in the chat from Stefano Laurenti. Thank you for this very nice presentation and congratulations for your results on the scope. 2 quick questions. First, what is the distance between the range shifter and the collimator? And second, what is the maximum aperture size you can mount on your applicator? Thank you.
So the distance between range shifter and collimator is, we have 67.5 centimeters from the collimator to the nozzle exit, and then additional 8 centimeters to range shifter, so a total of roughly 75 centimeters. And the maximum aperture size we can mount is a diameter of 4 centimeters. but I have to say that the maximum size I would drill of collimator shape is limited currently to 28 millimeters, because beyond I could not use a single central spot, but I would need to start spot scanning. Otherwise I lose the homogeneity, because of course it's then a Gaussian distribution at some point and not a flat homogeneous distribution within the collimator shape anymore.
So thank you very much. Are there further questions? If not, then I would like to thank you everybody joining this webinar. Thank you for your great questions, and thank you again, Patrick, for your great, impressive presentations.
Thank you very much. Thank you for the effort, and also thank you very much for the questions. Happy to have a lot to talk and discuss. Have a great evening.
Thank you.
Bye.
And then I would like to say goodbye to everyone, and I guess we will continue with this webinar series in 2 or 3 months with our next webinar. The topic is not clear yet. If you have any good ideas, just drop me an email. Bye-bye.